Hi, I'm Rehana Kader, and I will be examining important basic epidemiological concepts that we apply when we approach a public mental health question or problem. If we want to help improve mental health at the population level, we need to know what we are dealing with. So, when it comes to a public health approach, we keep 4 steps in mind. To begin with, you need to define the problem at hand. That's step 1. Say we are looking at the magnitude of the problem of dementia in adults aged 60 and above in South Africa. Then we move to step 2, and then we look for causes or risks and protective factors, which we sometimes call determinants or associated factors. In our example, we find that diabetes and high blood pressure are risk factors for developing dementia. While having a diet rich in fruit and vegetables may be protective against developing dementia, once we have data on steps 1 and 2, we can move to interventions which address these causes or determinants. We can aim to prevent type 2 diabetes and high blood pressure, or make sure a person's glucose levels and blood pressure are well controlled should they have the condition. And we can encourage healthy eating. So, in step 3, we develop interventions to encourage people to take their medications regularly, teach people how to grow their own fruit and vegetables, and train staff how to detect the early signs of dementia. These are all interventions targeting risk, protective, or associated factors, and early identification of a condition. Once we have tested the interventions and found that they are effective, we can continue to step 4 as we implement these interventions in healthcare facilities and communities. And then we follow people up over time to see how well these interventions are being implemented and how they are working. In this video, we are going to focus on steps 1 and 2 of the public health approach and look at some important concepts that can help us define a public mental health problem. Specifically, this includes concepts such as prevalence, incidence, and the burden of disease, along with measurement and caseness. At this stage, we also make sure that we think about sources of bias. We will then touch on identifying causes and associations, keeping in mind the principles of causality as well as confounding and bias. I will discuss the meaning of each of these items along the way. So, in order to define the problem, we need some information to describe it. What is the magnitude of the problem? In other words, how large is the problem? Or how many people are affected and in what time period? How much are they affected? We can start exploring these questions with prevalence, incidence, and burden of disease. Prevalence gives us information on how many people have a condition at a certain point in time. Incidence tells us how many people develop the condition over a certain period of time. And burden of disease gives us some idea of the health-related impact on people's lives at a population level. So, first, a definition. Prevalence is a measure of occurrence. It is a measure of how many people in a population have a certain health condition, exposure, or other factor related to health at a given point in time. So, sometimes we look at the prevalence of a health condition, such as depression. Sometimes we look at an exposure or risk factor. such as traumatic experiences in childhood, and sometimes we look at other factors related to health, which can be seen as exposure in a good way. In other words, protective factors, such as having a good social support. If someone was exposed to traumatic experiences in childhood, they are at risk of developing a mental health condition or symptoms of a mental health condition in childhood or later in life. But having supportive families and friends can lower the risk of developing a mental health condition. Another way of thinking about prevalence is to picture the target population as a large circle. So there are people who could have the condition, exposure, or other attribute. Let's talk about an example. We look at dementia, and we would say the population of interest comprises all adults aged 60 and over in South Africa. We can add a smaller circle inside the largest circle to show the people who actually have the condition, exposure, or attribute. Then, in our example, the blue circle represents all those adults aged 60 and over who actually have developed dementia. We express prevalence as the total number of people who have the condition, or disease, or exposure, or attribute, divided by the population at risk of having the condition. Here we have 100,000 divided by 5 million, which gives us a dementia prevalence of 0.02 or 2%. Then we have incidence, another measure of the magnitude of the problem. Incidence is the number of new health-related events in a defined population within a specified period of time. So, if someone is diagnosed with dementia in a certain time frame, they contribute to the incidence figures. If someone was diagnosed with dementia previously and thus was an existing case, we don't count them in the incidence calculation. So if someone says that they are talking about incidence, they generally mean cumulative incidence. We calculate cumulative incidence as the number of new health-related events in a certain time frame divided by the population of interest, which is measured at the start of the time frame. When we are talking about the diagnosis of a health condition such as dementia, we would speak about the number of new cases of dementia divided by the numbers of adults 60 and over, again in a certain time frame. Very similar to prevalence so far, but with people newly diagnosed only. Let's picture the prevalence and incidence of a health condition using the bathtub analogy. Say we are talking about anxiety disorders in Ghana. The bathtub full of water represents the prevalence of an anxiety disorder in a 12-month period in a particular population. So, this is everybody who has a diagnosis of an anxiety disorder. The tap represents incidence. As people develop an anxiety disorder during the 12-month period and are identified as cases, they are added to the prevalence bathwater. The prevalence bathwater level also changes over time. If people die or move out of Ghana, they are no longer considered in the prevalence calculation. They can also recover, and during the following year, they no longer meet the criteria for an anxiety disorder, and thus no longer contribute to the prevalence bathtub. Looking at this image, you can see that prevalence depends on incidence and a duration of the condition until recovery or death. And sometimes prevalence is also affected by migration. When the duration of a condition is short, incidence is likely to be similar to prevalence. Examples of this include the common cold. You catch a cold virus and recover in a short space of time. If the duration of a condition is much longer, such as a substance use disorder or major depression, prevalence will be greater than incidence. Talking about the frame is vital for incidence. If I say there are 500 cases per 10,000 population, that is a significant number of new cases. Maybe it's an epidemic. But if I told you that this incidence was measured over 10 years, that paints a very different picture. Assuming the incidence is relatively stable by year, we would average the figures out and come up with 50 cases per 10,000. As I said, a very different picture. Then we have burden of disease. This is where we go beyond just the numbers or proportions of people living with a certain health condition or the numbers of people developing a condition. Here, we start thinking about the impact of a health condition in a population. The Dictionary of Epidemiology also mentions that it is an approach to the analysis of health problems. It's one of the many tools we use to define the problem when it comes to a health condition. We express burden of disease using certain metrics, such as disability adjusted life years or DALYs, healthy life years or HEALYs, or quality adjusted life years QALYs. In public mental health, we often use the findings of the Global Burden of Disease or GBD study, which publishes new estimates every 1 to 2 years. This study uses DALYs, which combine years of life lost with years lived with disability. So let's have a closer look at DALYs and the GBD study. Here we have a rough timeline of a hypothetical person's life. The start of the timeline is their birth, and we can see that they experienced poor health due to a certain condition and an injury during their lifetime, as represented by the green blocks. The green blocks indicate the length of time that they weren't well due to the health condition or injury. In the reality, we all experience many more such periods of poor health, whether it is due to a twisted ankle, a mild cold, or something more serious such as a cancer or a chronic condition like depression or diabetes. Then we see that the gray blocks end at a certain point. And this represents the person's death. However, their age at the time of their death is a great deal younger than the current life expectancy. So the length of time from death to life expectancy is represented by the blue block. The green periods in the timeline or times when the person experienced a health condition and an injury are times when the person was living at less than optimal health. They were living with some sort of disability in these periods, even though, as we mentioned, this could be quite mild, such as having a cold. We measure these periods using the metric years lived with disability or YLDs. As mentioned, this person died earlier than expected, and the period between the person's death and life expectancy is measured using the years of life lost metric known as YLLs. As you can see, we have a metric of morbidity or poor health and a mortality metric. To assess the burden of disease, we take both of these metrics, so YLDs and YLLs, into account. YLDs and YLLs combine to give us disability adjusted life years or DALYs. Now, we have covered prevalence, incidence, and burden of disease, and we have a good idea of the magnitude of a problem. Or do we? Let's spend a bit more time on step 1 of the public health approach. When we start out to answer questions in epidemiology, such as the magnitude of major depression in a population, we need to plan and proceed with caution so we can come up with the best answers to our questions. Whether we are actually collecting and analyzing the data or reviewing published studies or reports, we need to ask ourselves, how were or how should the variables be measured? What psychometrically sound measurement tools are appropriate? What criteria are used for caseness? What are the potential sources of bias? We always need to be aware of these aspects as we approach epidemiological questions and data. So let's think about this a bit more. Before we start talking about prevalence, incidence, burden of disease, we need to know, what are we counting? Prevalence of what? So if I say that I am measuring the prevalence of depression or smoking, I need to be very specific about what I mean. This is where measurement and caseness come in. For depression, am I talking about the people who have a diagnosis of depression? If so, what diagnostic criteria am I using to define the diagnosis? Are these criteria according to the Diagnostic and Statistical Manual of Mental Disorders or the International Classification of Diseases? Or am I talking about people who have a certain number of depressive symptoms as defined by a cutoff score on a screening questionnaire? For smoking, am I talking about nicotine delivered via cigarettes, cigars, and vapes? Smoking at least once a month, a week, or on more than 2 occasions a day? What standardized tool will I use to measure smoking? It's extremely important to decide how we measure something and how we identify a case of the condition. Caseness is what we talk about when we say that someone has the condition or health-related state, and non-caseness is when someone doesn't have the condition or health-related state. These are central concepts in our efforts to define the problem. Another important concept to pay attention to is bias. What if we get it wrong? What if we say that someone has a condition and they don't? Or we say they don't have the condition and they do? Error and bias can creep into our problem definition work. While we can't avoid all errors and biases, we can put some plans in place to minimize them. We do this by careful planning of how we will go about defining the problem. We also pay attention to this bias every step of the way when using our 4-step public health approach. We need to be aware of bias in the way the research is conducted and interpreted. Biases are systematic errors in the way we find answers to EPI questions, how we conduct the study, analyze and interpret the data, and report and review the research findings. Errors creep into what we do, and also these errors may represent what we don't do. We say that bias refers to a systematic errors, which means that they are baked into the approaches used. And if we recognize the biases, we can predict the type of effect they will have. In other words, they will consistently change the results or what we report. Biases are not small errors that appear at random and then disappear. Let's compare random and systematic errors. For example, if my goat delicately chewed one of my questionnaires, removing that particular juicy question, then that would be a random error and not a systematic error, as only one participant would have been affected, and hopefully my goat didn't enjoy the taste of public mental health documentation, so he wouldn't try it again. Now say we have 1,000 questionnaires printed with part of a question on one page and one word of the question on the next. This could lead to field workers asking the wrong question. In the last 2 weeks, have you felt like it's difficult? Or maybe leaving it out by mistake? For the second step of the public health approach, we need to be very careful when we talk about causes, determinants, also called risk or protective factors, and associations. There are very specific circumstances when we can identify a cause of a health-related event. For example, we need to pay attention to temporality or timing. The cause needs to occur before the condition or event to make sure that we capture accurate information on what happened when. Ideally, we need longitudinal studies that follow people over time to determine whether an exposure is actually a cause of a certain condition or event. And we definitely need to keep an eye on potential biases. Then we have a tricky form of bias to consider, confounding. Sometimes in the research process, when we are looking at the effect of a potential exposure on a health-related event, we come up with an answer or evidence of an association which doesn't actually exist. One of the reasons this can happen is confounding. There's another factor in the mix that makes it look like the exposure we are looking at is related to the event. But it's actually the effect of that other factor. So say we are measuring employees' feelings of connectedness at work, and we measure a number of different variables. When we analyze the data, we find that employees who drink coffee are far more likely to feel connected to their colleagues. While many coffee drinkers may agree that coffee generally makes everything better, this is not actually the complete picture. It turns out that coffee drinkers in the workplace in question tended to talk to more people in the corridors on their frequent trips to make coffee. So when we included a variable measuring the frequency of interactions with colleagues, the association with coffee disappeared. It wasn't actually about the coffee, but about opportunities to interact with colleagues. So coffee was the confounder here. To increase feelings of connectedness in the workplace, we actually need to create more opportunities for employees to interact, whether it's an informal corridor chat or a more formal gathering. As you can see, we need to be alert and on our toes when conducting research and interpreting data. Bias and confounding do crop up everywhere and also make an appearance in steps 3 and 4 of the approach. Always keep these concepts in mind. So, this is a very brief overview of some key epidemiological concepts and where they fit into the public mental health approach. I hope this has whet your appetite a bit for more epi. These concepts do become clearer as we dive into the epi literature.